Okay, let's make a start, because as I said a couple of minutes ago, there's a lot to get through. Good evening, welcome everybody to this first meeting of the second week of our Acute Services Review public meetings. I'm going to introduce myself first. I'm David Rogers. I'm Vice Chair of Healthwatch Devon, and Healthwatch, as you may be aware, is the independent consumer voice for all those who use health and care services. We've been asked to chair these meetings because we're independent of all the other organisations that are responsible in one way or another for the STP and the Acute Services Review. Right, some housekeeping points. Refreshments, some of you have found on the table over in that far corner, but if anyone else is looking for a cup of tea or coffee, that's where you'll find it at any time during the evening. The toilets, either immediately after or perhaps some time after you've had the refreshments, are a long way through these double doors behind me here. You go through, I think it's 2 more sets of double doors, and then they're round to the right if anybody needs those facilities. As far as fire is concerned, no fire drill is expected, so if the fire alarm should sound, then please make your way quickly and quietly out of one of the 4 marked fire exits in the 4 corners of the room. So that doesn't happen. Right, just before I go on to the running order for this evening, you can see there's a considerable number of people behind me. They will form the panel for the question and answer session later, and some of them will be presenting as well. So I'm going to ask each of them to introduce themselves. You've got...
Hello everyone, my name's Phil Luke. I'm the Divisional Director for Operations at the Royal Devon Exeter Hospital.
Hello everyone, I'm Corinne Hayes. I'm a paediatrician and Associate Medical Director also at the Royal Devon Exeter Hospital.
Thanks, Corinne. My name's Hugh Groves. I'm the Chief Finance Officer for New Devon CCG.
Hi, my name's Jill Champion. I'm a Eastern Board member for the CCG. I'm also a nurse partner in a surgery in Exeter and an ex-pupil of King's College at Ottery. Thank you.
Many of you know who I am, Dr. Simon Kerr, GP in Ottery St Mary and Vice Chair of the Eastern Locality in New Devon CCG.
Okay, I think we've got a slide which shows the timings for the various sessions this evening. There it is. The 2 presentations will take place without a break between them for the Sustainability and Transformation Plan and then for the Acute Services Review. Then we will have a question and answer session to the panel. Obviously you can ask any questions you want, but please try to keep them as relevant as possible to the issues that we're talking about this evening. And then there will be an hour or up to an hour of table discussions around the tables where you're sitting. So the whole purpose of today then is to give some context on why there is a Sustainability and Transformation Plan for Devon, commonly known as the STP, to explain why the Acute Services Review is taking place. That's reviewing acute hospital and some specialist services as part of the STP. To hear your views on the important factors that you think should be taken into account in the next stages of this whole process, which is not just a one-off thing, it's something that will continue for quite some time to come, and explain how any feedback that you give, either the questions that you ask or what is recorded on the tables in the second stage of the evening, will be used to inform the plans of all the organisations, that's all the commissioners and all the providers in the later stages of the process, and also how you can stay involved if you wish to remain involved in the process as it unfolds. As I said, it's not an overnight thing, it will be carrying on for quite some time. Okay, so without any further ado, we'll go on to the first stage of the presentation, and this is Hugh Groves.
Okay, thanks very much indeed for that. As some of you may have heard, Devon is working on a sustainability and transformation plan, and I think the word Devon is pretty important actually. It's the old county boundary, and we'll go on to explain who's involved in that. There's been a number of changes in the health service over the years, but it's one of 44 STPs in England, and I think that makes it much more coherent, an area to work within and plan going forward. A number of you would have constantly hear about the financial challenges that all health services have, But I think it's really important to understand that these plans and the work that we're doing with our health services would be required anyway, irrespective of the financial position, and I think that's really important to take account of. And I think it will bring a number of benefits. First of all, really integrating the health and social system in delivery of services. And I think, as we all know in Devon, meeting the needs of ageing population, which are going to be so important going forward as well. I think we're all finding that there's continued increase in services, and to be able to work differently and work in a new way to manage those demands are crucially important. Clearly the money's not going to dramatically increase, and it's important that we're able to make best use of those resources. And I think in particular using new technologies and areas of advance that we should be taking advantage. We shouldn't be blind for the fact that there are continued clinical improvements, and it's important that we're best placed to take advantage of those going forward in the future. As I was saying, the Devon footprint contains quite a number of organisations and hospitals in particular, and those are listed above just to give you some idea, most of which I'm sure you'd have heard of, and many of which I'm sure you'd have benefited from contact with them. And it's not only the hospitals that you can see and the health services on one part of the chart, but importantly, it's the social services as well. And it's very much an integrated planning process and delivering that we're expected to work going forward. And I think the important thing and the important change is that organisations are working a lot closely together now in trying to deliver one plan for the whole of Devon, and to ensure that we can all make best use of the resources we've got, both clinically, technologically, and financially. So, I'd just like to introduce the video on the case for change.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be more than £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on healthcare for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They're also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high-quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
Thank you. I think that video summed up very well really the task facing us over the next coming months and the challenges for the years ahead. But just to emphasise just a few things. Clearly we need to ensure that we're continuing to improve health and well-being, that the needs of our ageing population are met. And I think in particular, as the film highlighted, the inequalities that exist both in terms of resource use and health outcomes. Clearly, high quality care is really important, and again, that was emphasised by our clinicians in the film. And I think a particular area of investment and review is in relation to mental health, and I think some concepts as well that people prefer. People prefer to be in their own bed by and large, but clearly there are times when that won't be able to be met in terms from clinical demands. Then finally, the financial sustainability. As we've said, do nothing means, and this is a figure that I find particularly hard to comprehend, even being a chief finance officer, 557 million difference in the space of a number of years if we do nothing. Clearly has a huge impact, and I think we all know the pressures on public funding. And then, as we say, an exercise in terms of making sure that we pay attention to the fair allocation of resources within Devon. And just want to emphasise, this is just one area of a number of priorities that we're looking at. What we're focusing on as part of the discussion today is the acute hospitals and specialised services. There are a number of areas which are equally important. I think prevention and early intervention is crucial to a number of things. I think issues around sugar, alcohol, weight, etc. Integrated care is particularly important, as is primary care and mental health, but the real discussion we want to get you beginning to have some input into and having some conversation about is the acute and specialised part of the services today. And with that, I'll hand over to Corinne.
Thank you. I mentioned I'm a paediatrician. I work at the Royal Devon and Exeter. I've worked in Devon for 20 years. So I work in Exeter. I also do clinics in Barnstaple, and previously I worked in Derriford. And I want to reassure you from the outset that I remain really proud of the care that we deliver in Devon, and that this exercise of really kind of coming together as the 4 acute trusts, as in combination with the Partnership Trust, with the CCG's primary care. It's a real sort of, it is a great collaboration, and it's really exciting that we've got this opportunity to look at what we're doing and to learn from one another and think about how we can do what we're doing, continue to provide good care, but actually do it to improve on what we're already doing as far as possible. Now, there are a number of challenges, and the film highlighted those. The challenges are that we haven't got enough staff in all the care centres, in particular the acute trust, which is what this part of the review has focused on. And also what's happened is that there's an increasing ageing population. People are living longer, as the film said. They're living with chronic conditions. So the complexity of needs of patients has increased, and also our technology and what we're able to do has improved, and it's trying to get the best match of that technology with the patients, so we get the patients in the right place at the right time to have the right care as far as possible at all times, and that's the real challenge here. The standards have gone up. There are many regulatory governing bodies which impose standards, quite rightly, and I've seen that actually it's impossible for all the 4 hospitals to meet the standards for all levels of care, for all aspects of care. And so that's why we've got to look at how we can deliver the best possible care with equal access across the whole of Devon. So that's the challenge. The way we've done that is we've looked at the key areas, which is there's 3 working groups. The first is led by Adrian Harris, who's the medical director in Exeter, and that's looking at the emergency departments and the acute admissions of patients, whether that be surgical admissions or medical admissions. And there's a theme across all the 3 areas in terms of staff shortages. There aren't enough staff who've got all the skills that we need in all 4 acute trusts. Because of the increasing numbers of patients in emergency departments, we're not meeting the standards, the 4-hour target for patients to be seen, treated, assessed, and either discharged home optimally or admitted in that 4-hour target. And as I said before, what we want is for the patients to be in the right place to have that care and not be moving around through care environments which are inappropriate. The next group is the Stroke Services group, which is led by George Thompson, who's the medical director in Barnstaple. And we know that the outcomes for patients with stroke are improved if their care is in a hyperacute stroke unit in the first 72 hours. So there's really good evidence to say what we should be trying to achieve. What we know is that to have a hyperacute stroke unit in all 4 trusts is not achievable with the staff and the technology and the standards. So we need it to be in at least 2 of those acute trusts. But there will be, the reassurance is that there will be acute services, there will be the appropriate response in all the 4 trusts, and there will be thrombolysis available in all 4 trusts. But we just need to then make sure that the patients, if they need to be moved, are moved appropriately to a more specialist unit, if that is going to be associated with a better outcome. What's closest to my heart, of course, in paediatrics is the 3rd group, which is being led by Rob Dyer, who's the medical director in South Devon. which is looking at maternity services, which clearly links to neonatal services, so care of the newborn, including the very premature newborn, and paediatrics, both general and specialist paediatrics. There's the same recurring theme. We haven't got enough staff to staff our rotas of doctors, nurses, and therapists in all 4 acute trusts. We're using agency staff. We are therefore spending a lot of money on agency staff who don't necessarily know the way that systems work in the hospitals, and we need to work together to collaborate and think about how we can use the staff we do have in the most effective way possible. So why are we doing this public engagement? Because we need to know if we've got it right. So we've set up these 3 groups. We've come together as clinicians, as managers, with patient representation as well in those groups, to look at what we think the problems are and what we think some of the solutions are. And we're trying to establish criteria on which to base those judgments and to make those proposals for change. But we're not sure if we've got it right, and what we need to know is what you think are the priorities, what you feel are the most appropriate criteria, so that we can be sure that in doing this work that we make the right decisions, and we make decisions that also are sustainable, that they're not decisions that just sort out a short-term problem, but we really look at a solution, a model that will be sustainable for 5-10 years, and actually for the next generation. And clearly, I come back to the children, but in the film we talked about the number of children. We have really very sad statistics in Devon of a growing number of children who are presenting to acute hospitals with deliberate self-harm in very significant distress. And we need to really go back to the beginning to see how we can get that right, working with schools and working with social care, to ensure that we improve outcomes. So we are thinking it needs to be really a plan for the next generation. So these are the criteria that we've come up with, and they really echo some of the aspects of the presentation that we've already heard, including the film. But the purpose of today is to find out from you, are these the right criteria? Thank you.
We're about to go over to you to ask any questions, either to hear more detailed explanation of what you've heard in the presentation, or indeed to put any other questions that you would like to do. We should all need to use the microphone because this part of the session is being recorded as part of the feedback process. So if anybody has any unwillingness to have their view recorded, then please could you let James know, who is standing over there, and I think he will then take the necessary steps to deal with that. Yes, madam. Oh, you're wanting to get in, right? Okay, I'll come to you first. Okay, so that's we've now got quite a long time, at least half an hour, to deal with questions and answers. So they can be either about the sustainability and transformation plan, which is the first part of the presentation, the 7 priorities that lie within that, and anything that was not clear from that, or about the part of the presentation, which was the acute services review, and the issues within that Corinne was just talking about a few minutes ago. Right, I won't waste any more time. I will go straight to the lady who put her hand up first over there, but I will certainly come round to all the tables to make sure that everybody has a go.
Thank you. I wanted to ask about the quality and outcomes criterion with regards to clinical benefit and improved outcomes. Under the case for change, there have been lots of requests from the public for detailed information on the clinical evidence with regards to how decision making was arrived at. And I know that there are still requests for information that are outstanding. So I would personally find it very difficult to make judgments about which are the right criteria for decision making when it's not clear in a kind of a catch-all statement like that what the clinical outcomes and benefits might be.
Could I ask whichever member of the panel is going to introduce that, and in fact all of you, when you first speak, to say again who you are and what your role is in this process?
Okay, thank you. So I think it would be useful to say that more or less every day, we as clinicians, certainly I more or less every day, spend time looking at the information on the quality of care and the performance of our acute trusts across Devon. So all the cancer targets, for example, all the A&E targets, all the ability to see patients within 18-week targets are presented to us at the Clinical Commissioning Group to review. And as you will imagine, different trusts are performing differently, and those targets change, and all those achievements, achievements and their quality change all the time. And those achievements are then risk assessed and are profiled so that we can look at what's in place to try to change the achievement of those targets or to improve the quality of that care. So that's and there are probably 130 different risks that we monitor in the CCG all the time. There are also quality markers that we review at the Eastern Locality Board on behalf of the Eastern Locality here, and that's now a board that meets in common with the Northern Locality. So we review the performance of the acute trusts and also the community trusts in terms of their quality of their delivery and also their performance in terms of meeting the national targets. So that's, and we can share that with you if you're interested in seeing that, but we do continually monitor that, and I think that's how we would, those are the sort of targets and those are the sort of performance that we would use and we would want to keep an eye on to make sure that anything we do, anything we change actually improves what we're currently seeing.
Okay, anyone want to add to that? Although I should say at this stage there won't be time for all 5 of you to answer every question.
No, I'll just make a general comment. So this is in response to some of the issues that we are facing now, as we've heard, in relation to sustainable services. So there are issues about being able to recruit the appropriate number of staff, qualified staff, to provide the services as well. So it's not necessarily shifting from one model to another. It's having to ensure that we're able to maximise the resources we've got in able to respond to the demands for the future.
Okay, anyone else from this table before I move on? Right.
I don't envy any of you your job and the very difficult decisions that you are going to have to make. And from my part, I think that the way that you've communicated and engaged us lot has been really good. Thank you. My area of interest is the stroke slide. And the stroke slide talked about hyperacute and acute part of the stroke services. The STP looks at the health and well-being challenges, and also that health and social care should make better use of resources available. So my question is around, does the stroke review and STP robustly address what is available for stroke survivors once hyperacute, acute and early supported discharge have done their very excellent work? And I like the fact that somebody's nodding their head over there as well.
Hi, I'm Phil Luke from the Royal Devon Exeter Hospital. So I suppose, just to answer your question, there's a lot of work looking at the what they call the hyperacute, the kind of first bit of the pathway for patients who've just had a stroke to make sure they get the right care. But there's also a lot of work looking at how we centralise rehabilitation and put services in the right place to make sure the patients do get the right care. So I think the point you're making is absolutely right, because if we don't get that part of the pathway right, we won't have the capacity to treat patients as they're coming through the system. So you're completely right, and yes, we are looking at that. Do you mean in terms of care at home, or do you mean rehabilitation? Yes, rehabilitation. Yeah, so that is certainly being looked at, and there's changes being planned to address that, and to make sure that patients can get continuing care at home for where it's suitable. I'm sure it will. I'm not an expert in stroke, but I'm sure it will.
I think it's a really good question, and I think what this review has done is it has highlighted that that once you start thinking about each individual pathway, that it throws up more and more questions. And so that, I mean, I'm not involved in that pathway, so I can't speak to it. But what I am aware of is just the culture of making us think about what we do, and what we do in around the whole of Devon has really become embedded in the way that we do everything now. So I've been looking at rehabilitation services in Exeter, and we're now going to what can we do in terms of sharing the expertise, the resources that we have across the whole of Devon. So that is happening, just to reassure you. So that's why we were nodding, so, because it's really key that we think at every aspect of the patient pathway. So.
Okay, we need to move on to another subject now.
Thank you. I'm Robert Crick, and I was once Dean of a very large nursing and midwifery college in North London. So my concern is about training. A cluster of your problems, the financial shortfall, the use of agency staff, etc., focuses on this issue of staff recruitment, staff retention, staff training, and staff development. And my question is, in the STP, what scope do you have to make any impact on what is happening? My daughter-in-law recently qualified brilliantly from Exeter University as a radiographer, and she's doing very well, but she's currently at my home suffering from stress, and is finding that the way her schedules are being manipulated means she's going to have to give up because she's got a small child, and we can't go and look after our grandchild in Bath while she's in there. That's just an anecdote to go with a major problem. Where are we going to get the new staff from? How are we going to keep them? You've taken away, not you, they have taken away all support for students studying for these programs. And I'm concerned, and I admire your wish to do this. Do you have the power, the scope, the opportunity to operate independently in the Devon STP against the national trend of dismantling staff retention and morale?
Hello. Yeah, in the STP, workforce is really, really important, and it's really important for the reasons you've absolutely highlighted. And I think there's two aspects of this. One is the supply of newly qualified clinical staff, and then retention. What we have found is that there are different practices in different hospitals, particularly around the retention side, and attracting people to work for hospitals. And one of the groups that I'm personally involved in is looking at how best practice can be shared with one another. So there's certainly something around that. But you're absolutely right. The supply side is something that again is another challenge for the STP that it needs to respond to as well. And there are many areas of work that we are looking at to try and improve that. If anybody else wants to add anything around that?
Yeah, I think there's somebody here who would like to.
I promised myself I would keep quiet. I'm Angela Pedder. I'm the lead chief executive for the Successorate. Forgive me for keeping my coat on, but it was quite cold when we first arrived. The workforce question is really important to us. And do we have independence? The simple answer is no. But there are flexibilities that we can use, and we're very pleased that our STP is one of the pilot sites for the new assistant nurse role, which is both working in the hospital service and in the care home sector. There is a challenge in terms of recruiting, certainly nurse education locally, because up until very recently, the only place people could do their educational component was at Plymouth University. But we are in conversation, and I think it's this September, the school in Exeter will reopen, so we'll have another satellite site that we can work to, because what we were finding is many of the nursing students had very long travel times to get to their placements. So it's not perfect, and we need to work within that. But the change to the bursaries this year has impacted on the number of people applying for nurse training. However, nurse training places were still oversubscribed. So whilst the number's gone down, the number of applications per post is still higher than the number of places that we've got. So we have to work hard on that. The other thing we're doing, and I saw an advert very recently, is that we're building our apprenticeship programme. And we're also trying to offer different routes of access for young people who may not feel ready at 18 to go into, or 16 to go into a nurse training placement, or may not have the academic standards at that point. But if you can create different gateways and different opportunities for people to come into training, then we need to do that. So through the STP, I think we have the ability to influence the centre in a different way. Whether that will change anything, I don't know, but I'm a glass half full person. If you don't try and you don't put the information together, you can't have the right dialogue.
I promised this gentleman I'll come to him, but I just wondered whether the lady who put her hand up here, is this on the same issue? It is, right. I thought it might be, so I'll come to you first, but I haven't forgotten you.
Hi, I'm just answering because I work for the Royal College of Nursing, so nurses are really important to me. And I am one as well. I would just say, from what Angela was just talking about, the nurse associates, they're not to replace registered nurses. And just want to make that really clear, that they're not to replace registered nurses. It is going to be a different way of perhaps bringing people into the profession, but we do have a massive problem of retaining good nurses. And I think as a system, there really needs to be an awful lot of thought about how do you keep good people at work? Because what I hear on a daily basis is people are worn out and they can't do everything. They can't work days, nights, weekends, not have a day off, do a day followed by a night, followed by a day off, followed by a whatever. So there needs to be some real thought around the workforce, and that's not just for nursing, that's for the whole workforce. But I did also want to say about the thinking about what we heard earlier about the 4 different organisations and the workforce probably needing to be shared around the system, that we need to think about enablers rather than disablers. So, having a contract perhaps, which covers everybody that works in Devon might be a really good idea. But we do need to listen to what folk need. Going back to the access issue, I think a suggestion that we can do without any of our acute organisations doing what they do at the moment probably isn't going to be acceptable, because the access issues will just be so difficult. Getting people to travel from North Devon down to Plymouth or wherever is, I think, probably a question too far, really. Sorry, I got all my points in one go.
Thank you. Well done. I'll come to you now.
I think you make your points very well. I think we are working in a new and different way, and it's about changing our cultures so that we're a learning organisation and learning across Devon. And I think that is a way forward. I think there are some excellent examples within Devon where there is good retention, other areas where it's more difficult. And I think it's about learning from each other, having open, transparent conversations, and also valuing our workforce. I'm taking some of the learning, particularly from Australia, around self-rostering of staff and listening to individuals. So I think you make very good points, but it is something that we've got. I think it's the first time that we've had a workforce, an organisation development group across the whole of Devon. And I think it's got huge potential. And with Angela, I think our glass are half full. I think it's going to be difficult, but I think it's good to have these debates. So thank you for your comments.
Okay, is there anyone on the panel who can take responsibility for the contract point that was made, a single contract across Devon?
I can't necessarily take responsibility for it, but I think it's a good
taking
idea.
It forward,
I think it's a good idea, yeah. And certainly it would naturally fall into the plans that we would have to ensure that we use the best use of all resources in Devon as well.
Okay, right, gentleman next to me.
Thank you. My name is Philip Elgar, and with others I was working very hard to try and keep the inpatient beds at Ottery Hospital. However, I don't want to go into history, but what I do want to do is just to concentrate briefly on one particular point which intrigues me. There are hundreds of questions I could ask, and all of us, but let me just concentrate on one. Various senior people within the NHS have assured us repeatedly that no alternative systems will be implemented until clinically they are proved to be equal to, at least equal to what we have now. We all know, and it's already come out in some of the questions and answers, that you don't have enough staff at the moment to man the existing system. So please can you tell me how on earth an alternative system is going to be staffed? It seems to me that that is a promise that has been made by senior people in the NHS, which frankly is never, never going to be honoured. Thank you.
You can hear me? I'll just stand up, shall I? So I think the point you're making, because there's so many different groups of staff in the NHS, it's impossible to give a guarantee kind of that you'll have like replacements of groups or you can staff in the area. But the kind of things we're looking at, which we are in a better position to look at as a collective, all the organisations working together on their own, are things like, instead of trying to recruit enough staff to look after patients in acute hospitals, is to focus on things like keeping patients healthy at home, and so recruiting a different type of staff who can support people living at home. So to do that, you don't need to recruit lots and lots of trained nurses who've been through the whole system. You can recruit domiciliary care workers who can provide that support in the community. So there are some answers which will help provide that without just needing to recruit more staff. But I agree it's impossible to give a guarantee across all different working groups. There will always be a like-to-like.
Okay, I need to move on to another table now to ensure fairness. So I'll come back to the people behind me if there's time.
Right, if you go into the RD&E, you're like going into a place which is like the United Nations and people working there from the sort of the four corners of the world. In the sustainable and transferable plan, is there some form of Brexit impact statement? Because clearly on those green benches in Westminster, there's some key discussions taking place. Will 3 million EU workers be allowed to remain in this country? So it's critical about the relationship with adequate staffing in relation to the Brexit question. Thank you.
Yes, Angela at the back is volunteering to take that one, which I think has a political dimension.
So the simple answer to your question is no, it doesn't have a Brexit statement in it, because we were drafting it before the Brexit review, the referendum took place. And across the NHS, there's about 120,000 EU nationals that are currently employed in the NHS, in addition to many other nationals who support the work that we do. We know that nurses are on the Home Office list to allow people to get work permits to come into work. They're a shortage specialty or a shortage occupation, and therefore that's something we've had to push for, because at one point there was a suggestion that nurses would be taken off that list. We don't know at this stage what the impact of any Brexit negotiations are going to be. I was driving in tonight listening to whether the bill will go through tonight, and we have assurances that the position of EU nationals in the UK and UK nationals in Europe will be taken into account during the negotiations. All the messages we're hearing from very senior people within the NHS and within government is our needs to continue to have an overseas workforce and a European workforce are recognised and will feature highly in the conversations that are taking place. And at the moment, we need to work within that. If we had to recruit or replace 120,000 additional members of staff, then the conversations that the gentleman earlier was asked in terms of the numbers in training and all of those things would need to be taken into account. But it isn't something that can happen overnight. And I think all of our hopes are that the staff that we have from overseas will continue to be allowed to work, but none of us can speculate on the answer to that.
Okay, we're about halfway through the question time now. I haven't seen anybody indicating from these two tables, or indeed the far one over there, so I need to just gauge some idea of how many might wish to ask questions. Right, now, yeah, I know there's more on this table. Right, okay, well I will start here. Was there somebody else as well on this table? Yes, okay, I'll take the two on this table next.
This refers back to the point made by the lady from the RCN who said that people would not accept any concentration of services. And looking at, because of difficulties of access, and looking at your criteria, I think it would be extremely helpful if they were weighted differently for different services. For example, if I have an acute stroke, all I care about is outcomes. And if that means being put into an air ambulance and ferried across the southwest, so be it. Whereas for an outpatient appointment, I want something accessible. So I think you need service by service to unpick the rationale, the need for change, which in your brochure is very, you've got a number of factors muddled together or mixed together, and they aren't clearly distinguished. If those were service by service distinguished and perhaps the criteria weighted, and then people might accept the need for change.
I'll just accept our nods as agreement. I think that's right. So it is very important that those criteria are appropriately weighted at the right time, and we'll take that as an important part of the feedback from tonight.
And what I would like to know is why is Devon given less money per head, both in education and in medicine? I remember when Angela Pedder was running the RD&E so well that when we went overspent, she said to me that if we'd been Bristol, we would have had a surplus. So why, can't we get, I've written to my Member of Parliament and one or two others, had a very stroppy reply back. I said that I thought that Southwest Members of Parliament ought to really make damn certain that this part of the world gets an equal share of what money there is. The other thing that I wanted to say is, why on earth are people having to pay to learn to be a nurse? It seems to me absolute madness. We're desperately short of them, and girls are going into debt to learn to be something we need desperately. Surely that oughtn't to happen.
Yes, I'm not sure that there'll be a local answer to what is clearly a national issue on that second point, but who would like to tackle the first point?
Thank you, Chair. That would have been my answer to the second point, certainly. And I'm happy to provide some more detailed background to the allocations of Devon CCG as well. But the reason we don't do quite so well in Devon is there's a greater weighting to deprivation in the formula than there might be to age, put it in simple terms. All those factors are weighted, but that's the real reason why we perhaps suffer less per head of per population as a mathematical calculation. Whether that's 100% right, there are many people in academia who are still discussing and debating those. What we've accepted is the fact that those are the cards we've dealt with. From a STP and those organisations in the NHS, we can provide information, but we're not really in a position to do any political lobbying in that sense. But we're taking that as another challenge. I'd have to say that every CCG in the country also feels exactly the same way about the formula as well. So it's not unique to Devon, but that's not to say that there aren't arguments for it either.
Okay, well, I think that was a very subtle encouragement to all of us as citizens to play an active role. Anyone on this table?
Certainly go and support that.
No? Right. Any more on this? Yes, I can see you. Any more on this? Any more on this table before I move back over there? No? Okay, good.
Good evening. I'm guilty of being one of these old people in Exmouth, or in Devon, actually. I'd like to know, Exeter is the fastest growing city, I think, in the country now. Can you tell me, or do you have any idea what the population growth is in Devon, and how we're struggling now, how are we going to cope for the future? Is this planning taking place for the future of the growth of Devon?
So that is definitely one of the factors that we've highlighted here in terms of population is going up and it will increase. That is something that does in part take account of in the funding formula, but it's probably not, that probably isn't going to grow as fast as the demands from our population as well. As you say, Exeter is possibly an exception. The rest of the country, the rest of the county is probably growing much lower than national average. But that's not to say that that increase in demands are going to come through changes in our population and in the demands that brings for health. So it's definitely something we'll need to take account of in our plans going forward. We can get hold of those, yes. Yeah, I haven't off the top of my head. No.
Okay, anyone else on this table?
I come to these meetings and I hear what's wrong. I hear the debates and everything. Are we ever going to get where we want to be? Please tell me.
So we'll answer. This is part of the purpose of the start of this whole planning process. So we've identified that working independently as NHS organisations, we certainly don't get the best out of the resources we've got. This is definitely part of a new arrangement where we're working much closely together to try and use the, as we said before, the technological, the financial and the workforce resources that we've got. Whether it will achieve everything that we've set out to achieve, who knows? But this is a much better way of dealing with that. And all organisations in Devon, including the County Council, have signed up to this method of approach as far as our plan is concerned. So I think we've got a much better hope of delivering the needs of the population of Devon rather than carry on as we were, which was a little more independently.
Okay, as I said at the beginning, Healthwatch is independent of any of the people actually involved in the process, but very happy to be involved in chairing. I would just add to that point that from my experience in the past, NHS organisations have not been particularly good at listening to what people say in relation to the use of services or how they might be different in the future. And I think the point was already made by one of the earlier questioners that this process is actually doing that, and it's up to all of us to play our part in it and see where we can get to. Right, back to the table with all the questioners. I've got the gentleman here and the gentleman there.
Thank you. Thank you. My name is Chris East from Sidmouth. Hugh Grove said that people are asked to be treated as locally as possible, yet all 44 STPs looking at the new models of care on the acute, as far as acute services go, is one of centralisation, whether that's paediatrics or A&E even. So that doesn't seem to make sense to me. It seems as though the reorganisation is coming from the top. You're being told what to do, and that you really don't have a great say in this. And it's as though we are being taken for fools. And I just wonder what you'd like to say to that.
Perhaps I'll ask one of my clinical colleagues to add a little more onto the clinical model about care close to home and then centralisation. Both things are true, actually. But just to reassure you and assure you that there's been no central direction on how we model things in Devon. Clearly there are trends in medicine and there are trends in good practice and evidence that we're hearing previously about what is the best setup, and those we clearly want to mirror and organise ourselves again to get the best value for money out of the resources that we've got. But there is no central direction about certain things being absolutely centralised or decentralised in any way. But perhaps I'll ask my clinical colleagues to add a bit of a clinical example to that.
You know, I think it's a really key point because it does create anxiety for the community that we're going to lose services. And I think the point you made about how we provide services, it needs to be actually the individual service that we look at as to where it should be provided and how, because that care as locally as possible has got to be the best quality care, not just any old care. And that's what worries, that's the worry, is that you dilute expertise and then we don't have the sort of high standard of care that we know we can achieve. So I can give an example, because I'm a paediatrician. I work particularly looking after paediatric oncology, children with cancer and leukemia. And that's an area of work where we've seen that the outcomes, our survival for those children now has increased significantly. So for the commonest leukemia, it's over 90% of those children who survive and survive without long-term effects. And that's only been possible through centralisation, but in a network, so that the children go for some aspects of care to Bristol, but we keep as many aspects of care as close to home as possible, whether that be in their local acute hospital in Exeter, or in fact for Devon we do all of the chemotherapy in Exeter for North and South Devon, and the families recognise that they've got to travel, but they're travelling for what they see as quality care. And if we can keep those kids in school, we've got nurses who go out and do visits at school. So we're looking at each part of the pathway and making sure that it's care that can be local if that is not compromising quality. But if we can get better outcomes by consolidating resource, then that's what we're aiming for.
Okay, sorry, was somebody else adding to that? Yes, okay.
Just going to say, just to support the proposal, that a lot of these priorities that you see here in the STP have been built from grassroots up. You'll see there integrated care. Now, as many of you will have heard me and others say, that the new model of care was very much built by clinicians talking to clinicians across primary and secondary care. And the words that went into the STP in all of these 7 areas were created in groups of clinicians and admin and management staff working together to say what are the most important things that need to go into these 7 priority areas. Primary care, also we are working with GPs now across the whole of the STP footprint, so South Devon and Torbay GPs working with GPs in Western, Eastern and Northern Devon to work together at understanding how they can work most efficiently together in all sorts of different ways. And mental health, I was very much involved in the conversations with both primary and secondary care clinicians working in the mental health world, trying to make sure that everything that we put into the ST priorities around mental health were driven from grassroots up, from those of us who are on the front line experiencing or working with patients suffering mental health issues. So just to try and reassure you, I think what we put into our STP was very much driven by conversations that clinicians have had in Devon, and not necessarily something that we've been told to put in by somewhere further up country.
Okay, we very shortly need to move on to the table discussions, but there is one more gentleman on this table who has a question to put.
Thank you. This is probably a question about governance. I've heard and very impressed with what our paediatric nurse was able to say about the improved treatments. It does seem to me that a large proportion, but not, as Mr. Groves was saying, 100% of the changes that are proposed in methodology and all that technical are derived from the improvement in medical science and technique. I think most of it is. But there is an element in there which is still lingering in the back of people's minds that it's about saving money only. And you did open up with the horrendous figures. I've been sitting in on the urgent and emergency care work stream, and it's clear that these facilities, and presumably in the other areas as well, are going to be shared. Because the method of doing it has to change even if the location doesn't altogether change. They've been thinking about how you can have partnerships, how you can change various techniques and experience and move staff around and still have jobs which are attractive for people to do. But my question is whether you are within the STP quite happy with the coordination of the partners who are in your STP. You know, the internal market was invented to introduce competition, and all it introduced was rivalry, especially in a time of austerity. And that can't be good for anybody, and so there have to be some governance issues about knocking heads together. And the head that wants knocking most together is, of course, the county council, because their provision of social care is one of the major factors, as you've all said, of the fact that, you know, bed blocking or whatever you want to call it. And so I'd be quite glad to have your views on whether you can trust the patterns of governance that we have, especially when it comes to the county council as part of the package.
Well, I think Angela is indicating again that she feels able to shed light on that one.
I think given that it's the STP and I lead on the STP, rather than asking my colleagues to give you an answer, I'll try. So I think it's a very reasonable challenge to make, because the 2012 Health and Social Care Act set out the various organisations that we have statutorily, and none of those arrangements have changed. So within the STP, all of the organisations that have come together to deliver the STP have done so out of choice, and all of the decisions that we make have to be endorsed individually by the CCG governing bodies, by the trust boards. So it's quite a complex process. However, the fact that we have come together, I think, underpins the fact that we all recognise working in silos doesn't work from a patient point of view, doesn't work from a society's point of view, and we are spending collectively the same taxpayers' resource, so we have a duty to spend that more appropriately. In relation to the local authorities, so for us it's Devon County Council, but also there's Plymouth City Council and Torbay Council. They have been very closely involved in the work that we've been doing. They've been very supportive. And I think the point I would make in relation to social care is we are finding it incredibly difficult in the health service, but our financial settlement over the last 5 years has been significantly better than the financial settlement that social services have had. And indeed, at least in this the last budget, some of that has been recognised, and the Chief Executive of the NHS has said, if we would like more money for health, but actually we believe there's a bigger priority first in putting more money into social care for a lot of people. So the engagement's been strong. Devon County Council has not cut its spend on social care. They've had to find funding from elsewhere, so they've been relatively balanced compared to many local authorities. But we do have a challenge that we need to work together. But what we were finding is that if health and social care aren't working together, then we're not making the best use of the resources that we can have. But we do have different funding mechanisms, different governance mechanisms, and it is complicated. So most of this has to be done by consent and organisations agreeing. And I've been asked the question before, I have no powers and I have no authority, but I can be quite persuasive.
Right, well, on that optimistic note, I think we need to move on to the table discussions. I'm not sure who's got control of the slides at the moment. If whoever has could move it forward to the one that talks about that. Yes, there we are. I mentioned this as we started the Q&A because those are the key issues to concentrate on. That's still the case now for the table discussions that are about to take place. I noticed that there are some tables that are sparsely populated, and there are others that are not overpopulated, but more well-populated. Now, if you want to stay that way, that's fine, but I'm not sure whether we have enough facilitators to make that work as well as it might. Kerry, I wonder if, have we got enough facilitators for each table? We have, okay. Right, well, if you want to stay as you are, that's fine, but if you want, especially the two people who are somewhat isolated over there, if you'd like to join one of the other tables, or have a facilitator all to yourself, maybe, I don't know. Anyway, right, the issues up there on the screen are the ones that need to be thought about. Have the principles of the STP been explained well enough? What do you think about the priorities within the STP, the 7 that were indicated and are on the board, which is to the right of the panel as we look at it? And then in relation to the acute services review, are the evaluation criteria the right ones, and what do you feel are the most important issues within those. There's up to an hour for this part of the process, but we don't need to take as long as that if you feel after 40 or 45 minutes that you've had enough time. I'm sure the facilitators are about to indicate who they are, if that's not already clear, and over to you then to have these table discussions for the next period of time. Thank you.